Hi, everyone. A very good morning to all of you. Thank you so much for having me out here. It's indeed an honor and privilege to be part of this Cancaware 2024. I was here in 2022 when it was in a much smaller hall with a smaller group audience. And it's nice to see how big the program has grown. So, heartiest congratulations to all of you. And it's really inspiring, especially the performances, the music that brought in a lot of energy. And with no doubt, the wonderful talk we have had from a cancer survivor himself. And it truly speaks volumes of the progress we have made in tackling this particular entity. Each day we learn newer things about this entity. Knowledge is growing. We are unlearning our own mistakes of the past. And it's important to first acknowledge that each day we unlearn something that we thought was the standard of care and are moving towards a different era of treating cancer or identifying cancer. I remember as a kid in school, we always thought that cancer was for the old. Cancer was probably not curable, was more about palliation. And 20, 30 years from then, things have changed dramatically. I bring greetings from Vaidehi Cancer Center, which is right across from where you stay. Of course, everyone's aware of Siddhartha Mukherjee's terming of emperor of all maladies. But when you look at it, what are these cancers? They're actually part of our own body. It's very innate. It's part of us. It's like our hand or leg or heart or lungs. It's very much our own creation. It's probably something that everybody creates, especially men. This is probably the only thing you can be even proud of having created because we don't give birth to young ones. So this is something that you have created. But of course, our own defense systems fail to understand that this is foreign and it quickly becomes a matter of life bar death. And that's why it's important to understand. And the commonest question that we often get in our OPDs is, I'm a very good person. I'm a complete teetotaler. I've had nothing. I've lived a very simple, pious life. Why me? Why have I gotten diagnosed with cancer? Long ago, Hippocrates used the word karkinos from Greek word and it described it like crab-like, wherein there's a particular group of cells which are growing across everywhere. Look at the advances we have made in understanding the genetic and molecular subtyping of cancer. We are looking at various terms of genomic instability, invasion metastasis, cellular energetic dysregulation, angiogenesis, immune destruction, growth suppressors, tumor promoting inflammation, resisting cell death. This is like a word seeder because every day in the newspaper you will read an article that says eat fruits, eat vegetables, healthy lifestyle, avoid stress, avoid smoking, avoid alcohol. All these factors are contributing to inflammation. We are trying to reduce inflammation. You'll read about CAR T cell therapy. You'll read about the cost associated with this kind of treatment, immune destruction, immunotherapy, targeted. You'll hear of what is big pharma, various industries trying to push. You'll also hear a lot about denial. You'll hear about homemade remedies to cure cancer. To be honest, there is no clear answer. All systems of medicine, you might hear something about traditional Chinese herbal medicine, cocktails and green tea that will prevent cancer from happening itself. Maybe there is some science to it, which we still don't know. I'm not here to debate on facts. I'm just trying to give you my interpretation of what there are. Because in reality, there is no such thing as a fact. It's only your interpretation of something. Because I'm colorectal and we are here in this audience, my boss would always say, opinions are like assholes. Everyone has one. It's just like that. This is just my opinion. And that's probably true across all spectrums of disease. Do we know enough? The answer is a clear no. We don't know. But are we learning something new every day? Yes, we are learning something new. And there's a lot of scope. What are cancers? Are they like runaway trains? Very similar. There's a driver who has accidentally gotten off the train. But the train is in momentum. It's not like as soon as a driver jumps out of the train, the train's going to come to a halt. The train's actually going to gain momentum and continue speeding, and finally it's going to crash. And that's how cancer sometimes comes across. Millions of cells which keep multiplying. This growth of cells needs to be regulated. There is always errors that happen. And if there is unchecked growth of cells, it results in something that is cancer. This unchecked injury in a genetic framework, with trying to simplify things, there are group of genes that are tumor promoting. There are group of genes which are tumor suppressing. And when there is an imbalance between these two genes, unhealthy cells escape repair and they become immortal. Sometimes, let's quote unquote, very few times, it is hereditary. You will find a lot of people coming and asking, I've had so many people with cancer. Have I gotten cancer because it is genetic? You'll probably find your doctor or clinician also tell you it's probably genetic. The actual answer is we don't know why someone got cancer. We'd like to think it's genes. But looking at statistics, less than 10% of all cancers are genetic. 90% of cancers are related to environmental conditions, probably tobacco, probably obesity, chemical carcinogens, irritants, pollutants, multiple reasons which ultimately affect the genetic framework. That doesn't necessarily mean we have inherited this genetic framework from our parents or grandparents. Is there a natural mechanism in us to prevent cancer? Very much. And are there therapies that are upcoming? Immunotherapy, targeted therapy, CAR T cell. It's all about channelizing our own immunity to fight against our own cancer cells. Our own body has failed to understand this is cancer. So there is a natural defense. Of course, when the natural defenses are compromised, when there are immunocompromised states, maybe this doesn't function well. So common immunocompromised states include diabetes. India is the most rampant thing. That's what we are talking about. We'll come to something about aging. We all think we are in our 20s, or we all know only our calendar age. We don't know our epigenetic age. There's a lot about epigenetic aging that contributes to cancer. So this is just a diagrammatic representation to say there are tumor cells. These tumor cells release certain antigens. Our body should identify this as foreign. The T cells or the lymphocytes and the immune system can go and attack these T cells and then destroy the tumor cells. There is a dysregulation in how this happens. And why are we here today celebrating or increasing awareness and conducting this event? It's because India is now probably, I don't know what's the latest update, this is an older slide, 1.42 billion people. We need to look at where we stand as a nation. So Globocon 2022 data is our recent survey with respect to statistics. We don't have India specific in Globocon, but we have Southeast Asia region. And in Southeast Asia region, the number of prevalent cases is almost 54 lakh. And it looks like 1 out of 10 people is going to have cancer. 1 out of 9 men and 1 out of 12 women are likely to have cancer, some form of malignancies. We'd like to look at what are the top 3. It's a very crowded slide. Let me just simplify it and say it out loud. There was a time when cervical cancer was the commonest cancer in women in India. That's completely changed in the last few years, and it's now breast cancer. Breast cancer is the leading cause of cancer death and incidence amongst women, followed by cervical cancer, followed by ovarian cancer in women. When it comes to men, it's tobacco chewing. We are still a large tobacco chewing company. Smoking related, oral cavity cancers are the leading cause. Next to oral cavity and tobacco is again lung cancers in men, followed by colon and rectal cancers. Colorectal cancers is almost third in the list. Prostate is again climbing up the ladder in the Indian scenario. It's important to know these statistics because patterns are changing rapidly. What was 5 years ago? We don't see those lymphomas, leukemias, Hodgkin's, blood cancers. Most often you would have seen a movie in the 80s and 90s where people actually had blood cancer. It was all talk about leukemias and blood cancers. No one really spoke about colorectal cancer. Nobody talked about breast cancer. Nobody talked about removing breasts back then. It was a very different era. But we don't have that incidence now. For every 1 lakh Indian population, 100 people are likely to develop cancer in their lives. 50 to 60 out of this probably will die some reason related to cancer. But does that mean there is no hope? I see hope is the beautiful tagline that's there, which is not true. If there are people who are living with obesity, like myself, if there are people who are living with diabetes and hypertension, if there are people who are living without a leg, why can't people continue to live and enjoy life, living and controlling cancer? So the whole philosophy has changed from curing to probably controlling cancer. That is where we are right now. It's okay to have a recurrence. It's okay to have a recurrence as long as you don't let the recurrence affect your quality of life. As long as we're able to control your recurrence. As long as there are medications to treat the recurrence. So that's what we are moving out now. They are equitably spread. You look across various districts. There's no specific region which you can identify and say is cancer free. All dense populations. But of course, you have a lot of northeastern populations which have high risk of cancers. So what's the trend? From all sides, when you look at head and neck cancers. Head and neck cancers are probably the largest volume of disease in India. Oral cavity, tobacco chewing. The annual percentage is changing. Prevalence rates are changing, but they still continue to be a predominant cause of concern. And what are these cancers presenting to us? It's common knowledge. We say that cancers have 4 stages. 0 probably is in situ cancer. Then there's 1, which is an early cancer. 2, which is borderline. 3, which is spread to the nodes. And 4 is probably a locally advanced metastatic cancer. But majority of our Indian population cancers actually present in the locally advanced stage 3. And that's where Cancaware comes into importance, raising awareness. Early detection saves lives. We don't actually choose to screen healthy individuals. How many of you here in the audience, if I were to give enough evidence to say that it's good to get screened, would be ready to undergo a colonoscopy right now? You would? Very few. Nobody who is healthy would say, let me get a blood test done, let me get an invasive scan done. I am healthy, I'm eating fine, I'm walking fine, I have no symptoms. That is when screening can save lives. When we have no problems. The moment there is abdominal pain or a breast lump or a skin discoloration, it is just early diagnosis. It is not screening. It is taking appropriate treatment to what has already been, macro level understanding. So screening is really important. So what's common apart from all of them having bad cancers? What is very striking? They're all very young individuals. So there was a time when we said cancers come in the 80s, then we moved to the 70s, we said 60s. And just today, the American College of Surgeons has released a guidelines to reduce colonoscopy screening to 35 years of age. From 50 years to 40 to 35, because it's affecting young adults. How many people in this room are more than 35 years? A raise of hands. We are all the highest risk of cancers. If you are, how many of us here are more than 60 years of age? Is anyone more than 60? If you're more than 60, you've actually crossed the risk. You're the lucky people who have survived the risk. People who are between 35 to 60, we are at the highest risk of getting cancer right now. And it's just a matter of statistics. If there are 100 people in this room, definitely one is likely to get cancer at some point in the next 5 years. So cancers in the young. So there is a sure shift which has been happening. So by definition, cancer in the young is less than 39 years of age now. And 20 to 25% of our cancers are actually cancers in the young. 2024 till date, at Vaidehi, we have had 17 young colorectal cancers less than 20 years of age. I'm talking between 15 to 20. We have had another 33 colorectal cancers between 20 and 39 years of age. There is a huge shift in our understanding of disease and who it actually affects. So the message out here is it's not just about you guys talking to your parents or grandparents. It's about talking to yourself in the mirror now. Things are changing. It's not about you going home and telling your mother or father to get screened for cancer. It's about you making a plan to get screened yourself for cancer. And that's a huge change in the way we have communicated. I used to do these talks where I used to tell the young crowd, okay, do something. What do you want to do? Is there something you can do to make a difference? Yes. Go home, talk to your mother, talk to your father, talk to your grandparents. No, no, that era is gone. Talk to yourself. Stand in front of the mirror. Look at yourself. What is your chronological age? What is your epigenetic age? You might think you're in your 20s, but your genes are probably 35 or 40 years old. If your epigenetic age is 40, you are at risk of getting cancer, not your parents. They've probably had stable epigenetics in their younger childhood and they've crossed the risk. You're probably as old as your father or mother in terms of genetics, and you're equally at risk for cancer. Common cancers showing a rise in young age: breast cancers, colorectal cancers, ovarian cancers. Again, fertility issues are cropping up rampantly. You can see lots of infertility centers across Bangalore itself. That's because most people who desire conception and want to raise a family land up having some fertility issues. Lots of medications go into promoting fertility. That itself can be a cause for rise in ovarian cancers. These are different trends. Yes, they are alarming. Yes, we can do something about it. There's no need to panic as such, but we can be aware of it. Now, what are the patterns of cancers which have really not changed and been stable over the last 40 years? Pancreatic cancer and kidney cancer. When we look back at kidney cancer, it's relatively remained the same incidence. What has really changed in pancreatic cancer? Their stage of presentation is still advanced. Treatment options are still naive. Screening is still very low. Even if you screen detect a pancreatic cancer, there's not much prognostically that you can do different on them. Cancers associated with obesity, that's again a really important thing. So environmental influence, we're talking about tobacco, alcohol, environmental pollution, stress. Again, see, genetics and stress is something that doctors use to rampantly when we don't know what's going on. The truth is, we don't know why it's happened. Maybe it's stress. Why did someone in their 35 years or 20 years have a heart attack and die of heart attack? Stress. I don't know. It's a very debatable issue. I have a completely different take on stress because I feel stress is what motivates us. It makes us achieve in life. It's good to be stressed out at some point. And I think, genetically speaking, most of us are used to last minute crashes and last minute timelines because we like that adrenaline. We do, sport activities, we do wildlife adventures. Anything that pushes our adrenaline is actually stress to the body. Very few saintly people who just do yoga, meditation, very, very pious. Most of us like the rat race. It gives us dopamine. It makes us feel happy. It gives us purpose in life. So it's difficult to eliminate stress. There's very little evidence to conclusively say that stress causes cancer. But yes, it's unproven association. Most people who are diagnosed with cancer eventually say they are stressed out, probably because of the treatment of cancer itself. It's a very overwhelming experience. It's overwhelming more so when you don't have the finances to back you. If you have the funds to get yourself treated and get the latest, it's easy for me as a clinician to order a PET CT. But am I sure that the PET CT is going to be the right choice? Many people, it might be their entire year's salary for the cost of one PET CT scan. It's 20,000 bucks. 20,000 rupees might be all that that lady is earning her entire year. She's probably a maid getting 1,500 rupees a month. And you say 20,000 rupees PET scan, and I'm not even sure that the PET scan is going to really help her. It's very, very debatable, these issues in society. Cancers associated with obesity, yes, breast cancer, endometrial, ovarian, colorectal, proven associations. Obesity, early onset colorectal cancer, because there's a lot of fat induced chemokines. Sugar, high sugary foods. This is the trend that we have seen. Now, whenever as clinicians we go back and ask ourselves, why is something changing so drastically? Colorectal cancer seen in 60s and 80s, now being seen in 40s. What's changed? Fast foods. The last 20 years, we have all been accustomed to consuming large quantities of sugar, day to day foods, which probably have a link to play. Again, I use the word probably. Inflammation, like we said, any chronic inflammation can cause cancer. Like I said, about 10%, 5 to 15% are hereditary. Lynch syndrome is there. There are lots of colorectal family cancer syndromes. Very few that we see in India, less than 10% that we see. Yes, this is something we should know. When do we suspect hereditary cancers? If there is a strong history, mothers, sisters, fathers, siblings, offsprings, you'll be surprised by the number of women who come for screening because their daughters have developed breast cancer. It's a change. There used to be a time when, the daughters would come in saying our mothers had breast cancer. Now it's the mothers saying, am I at a risk for breast cancer because my daughter has gotten diagnosed with breast cancer? Multiple cancers in the same patient, young onset, less than 39 by definition, can cause hereditary cancer syndromes or can be because of hereditary cancer syndromes. And in such patients, we need to screen them aggressively. Even when they are absolutely normal, we will subject them to all the tests that are necessary to try and pick up cancer. It can be frustrating for those people because we don't have definitive answers. Like you said, sir, the only thing that's certain is the uncertainty that's associated. We don't know. And it's important to realize that we know as much as science and research has evolved today. There's so much more that's pending for the future. Does stage matter? Of course it matters. Late stage does mean reduced outcomes. Stages 3 and 4, more tests, more consultations and doctors, more treatments, lengthier stay. And this is what actually is the cause of fear. It's not just one doctor. You don't just go to the oncosurgeon. He'll refer to a medical oncologist. There will be a radiation oncologist. There will be a pathology report that's pending. There will be a gastroenterologist who needs to do a scopy, a biopsy, a repeat scan. There is a nuclear medicine person who is involved in PET CTs. So there is a lot of doctors involved in cancer decision making. Now, women and cancers, yes, as we are progressing over from 2018 to 25, more women than men being diagnosed with cancer, 105 for every 1 lakh, increased number of breast cancers and lung cancers. But they're also faring badly compared to men. Unfortunately, maybe because of various reasons unknown to us, the outcomes in women are tending to be poorer than in men. More number of tobacco and smokers in the women, obesity, cervical cancers has come down thanks largely to the human papilloma virus campaign, the pap smear campaign, the vaccinations that have rapidly reduced HPV associated cancers. So yes, we do see more women with cancers in the OPDs. Breast and cervical cancers are the bulk of cancers for women. More women than men in our department at Vaidehi. More young women with breast and lung cancers. And yes, maybe there is a link. Women are generally more in denial. They tend to delay accepting that they have cancer and need treatment. Maybe. Now, just a quick overview on how we treat cancers now. This is what is like the highlight. There are lots and lots of evidence, guidelines. It's very easy to access this evidence and guidelines now with internet. But it's about individualizing treatment and about understanding compliance and feasibility. Many a times, people with particular cancers don't have the access to particular treatments. What has changed? Radical surgery to tailored surgery. We no longer remove the entire breast and chest wall for breast cancer like Hals did in the 1980s. We talk about just removing the breast cancer lumps. We have stopped about doctors feeling happy and understood it's about the patient feeling happy. It's not just about oncological cure, it's about functional cure. It's not just removing the disease from the patient. Is the patient happy? Functional outcomes, patient informed and directed approaches. Maybe the patient wants to avoid radiation and say, I don't mind the risk of 10% recurrence, because radiation is only going to reduce recurrence by 10%. But for radiation, I have to come every day for 6 weeks. I don't want to come for 6 weeks. It's about their functional understanding. About conventional neoadjuvant chemoradiation. There was a time everybody had chemo, loss of hair. Now we are talking about immunotherapy, targeted therapy. Come, take an injection, go home. It stays in a subcutaneous pocket. It works for 3 weeks. There are tablets now. Of course, we're also talking about completely avoiding surgery. Can we do away with surgery? Organ preservation, rectal cancers especially. Do I really need to remove the rectum which has had a complete radiological response and metabolic response? I don't need to do that. I can just observe them because they tend to do the same when I remove the rectum as well. So solid tumors, which we talked extensively, is about surgery, radiotherapy, medicines. Of course, hematological malignancies like leukemias, lymphomas, till date, predominantly targeted medicines and chemotherapy is the main line. We do have radiotherapy. We have image-guided radiotherapy. We have the cyber knife. You have stereotactic brachytherapy. There's a whole evolution that's happened in the way radiation is delivered to reduce toxicity and improve patient outcomes. Cancer medicines, again, it's really beyond the scope of this talk. I'm not going to bore you down with more than 10,000 drugs that are there in the market, and each drug with its own mechanism of action. It's just important to know that there are so many drugs. There's evidence, there's guideline, there's personalizing treatment. Not everybody fits every drug. It's easy to read a newspaper article and get carried away saying, okay, CAR T cell is there, I have the money, I'm going to invest 20 lakhs, I'm going to get my myeloma cured. It doesn't work that simple. You need to go meet your oncologist and discuss with them if that treatment is going to suit you. Now, where have we in the last 20 years made a difference? Cancers where the impact of treatment has been good: breast, head and neck, colorectal, endometrial, skin, and childhood malignancies. Where the impact of treatment has not been so important, especially liver cancers, pancreatic cancers, biliary tract cancers, lung cancers, certain types of leukemias, the aggressive blood cancers, and advanced ovarian cancer. So there is a clear subset of cancers which we can screen detect and make a difference, save lives, save morbidity. There's also a set of cancers where a lot of research is going on and there's scope for improvement. Stages 1 and 2 in breast cancer, more than 95% cure rates are achievable. But when it comes to stage 3, the survival drops at 5 years to about 40%. At stage 4, the survival is lesser than 40%. So why is it that there are certain cancers which are really good while some are bad? Because it's the tumor biology which we don't understand. And that's what, Professor Blake KD already said. Tumor biology is king. The surgeons and doctors are just like the queens and the princes. Sometimes they try to usurp the king, but ultimately it's the king who has his say. It's he who rules and decides. And tumor biology is just like that. So there are good cancers, there are bad cancers, in simple words. If you're lucky and have a good cancer, there's a chance of a 95 to 99% cure rates at 10 years, 20 years. On the other hand, it might drop low. Mortality trends, yes, we have reduced a significant number of deaths because of cancer. Men tend to do much, much better and tolerate treatments better. Deaths from head and neck cancer, stomach, breast, colorectal are the ones which account for the majority of deaths. Lung cancers and breast cancers, pancreatic gallbladder cancers, mortality has grown up. Stomach, esophagus, melanomas, things are improving and things have changed. And why do we say personalized approach? What do we do? Now, it's no longer just personalizing to the reports that we have, to look for genetic changes and to look at the tumor biology, to look at circulating tumor DNA. Yes, is there a big need and demand and mismatch? And I think that's where our role comes in. That's where the Indian Cancer Society is trying to pitch in a lot and trying to do more to try and reduce this treatment facilities. You'll be surprised that many of the districts, this is a very favorite map of mine, because at Vaidehi and CMC Vellore, where I worked previously, and at Narayana, we saw a large number of people from Northeast, West Bengal. And it's all thanks to that Yeshwantpur Howrah Express. It's the same express of train that goes all the way from Dibrugarh and comes down to Yeshwantpur, Bangalore. And, that shows how poorly our infrastructure is. These are patients in dire need of hope, dire need of good doctors and treatment. They travel all the way from there, come to Bangalore for treatment. And you'll find across this entire spectrum, Katpadi is there, that's Vellore, CMC Vellore, large number of population. Bangalore, Vaidehi, Hosur, you see lots of people coming across this state. Nellore Institute is there. Apollo Chennai is there. Vishakhapatnam Institute. Bhuvaneshwar has now SUMS, which has opened up a surgical oncology unit. Across this entire spectrum, it's because the influx of people who are coming not from our locality, but from outside. Lack of radiotherapy units. Radiotherapy machines cost a lot. It costs more than 50 lakhs, sometimes to the tune of crores. Variant linear accelerators are very, very expensive because the equipment comes from outside the country. There's a lot of customs, there's a lot of duty, and they're all assembled in parts. Maintenance is difficult. So there is a significant lack of radiotherapy units. So you look at this one study, 8 metro cities are home to 10.9% of the national population, but they use 38% of the radiotherapy services. So that's why there is a crowding in these metro cities. That's what impairs cancer care delivery, because everybody is concentrated in a few cities which have few of these radiotherapy units. Yes, there is a lack of specialist care, but there's good news. I think there's more than 1 lakh MBBS seats which has recently been granted by the National Medical Commission. We're hoping to see more number of doctors, more number of nurse specialists, more number of subspecialists in each sector who can improve the quality of healthcare. Health expenditure. Again, this is an important cause of cancer impaired delivery. 80% of Indian population have out-of-pocket expenditure for cancer care. How many of us in this hall have a dedicated account for cancer care or for any health care? Are we saving enough? Very few. I don't think we just probably have one account for savings. Many of the people don't even have that. And it's all out of pocket. Yes, there are some schemes which are coming up in national interests, which are probably going to revolutionize the way government and private insurance facilitates better cancer care. We have a lot of good help which comes from the Indian Cancer Society funds. We have bridging funds for 25,000. We have holistic treating funds for 50,000 rupees. We have also funds coming in from Ayush. We have Vajpayee Arogya Shri, we have the NTR scheme which is empaneled, and these schemes do help. And there is a subsidy that the Indian Railways offers for traveling. These are all going a long way in helping outcomes with the kind of people we see for cancer. Yes, what are the future directions? Artificial intelligence and machine learning is a big way. Awareness is important. Teleconsultation is important. And of course, a personalized approach to treating cancer. There was a recent experiment between AI algorithms as well as doctors. AI was able to pick up 90% of lung cancer screen detected with low-dose CT, whereas doctors were only able to pick up 50%. I know I say this as a doctor, but it's true. It's important to know our deficiencies because we are only human. It's human to err. Machines can pick up things better than doctors. Probably a balance between a doctor looking at AI algorithms is where we are heading in the near future. Just to summarize, cancer is something that can affect the young and old, the rich and poor, the black, white, or every color, male, female, trans, and other. right wing or left wing doesn't matter, whether it's east or west, it doesn't matter. There are followers who have cancer, there are leaders who have cancer, there are believers, there are non-believers in prayer who also have cancer. It affects everyone. There's far more that unites us than divides us. So let's all agree that people and the powers that be, to make this world aware, we need to close the gap in cancer care. Thank you very much. And thank you for giving me this opportunity to spread awareness about cancer. Let's hope that we save more lives and reduce the morbidity associated with cancer. Thank you.
Thank you so much, sir, for such an insightful and enlightening session. Your dedication to the field and your compassion for patients are truly inspiring. We are immensely grateful for the time and efforts you've taken to be with us today and for the invaluable knowledge you've shared. Let's all give a heartfelt round of applause once again to Sir for being a guiding light in the important cause.